The next talk is by Fernando Sipman from Madrid, and he's going to talk about lung recruitment. And in fact, we've changed things slightly. He was going to have a second talk on the circulation, but in fact is going to, because we've heard from the audience, there's a lot of interest in recruitment. Fernando's going to spend 2 talks on recruitment. The first one before lunch and the second one after lunch. The issue of circulation and acute lung injury will be addressed by John Marini's talk later today.
Well, first of all, I would like to thank McCabe for inviting me to be here today. It's always a pleasure to be in this amazing city, although the weather is not the one we're used to in Spain. But anyway, I'm enjoying the stay and the city. Well, actually, I propose to change the subject of my second talk because I was afraid of having a lot of overlap with John Marini's talk, but I realized that now I'm going to have overlap with the previous talk. But anyway, I think that recruitment is a sufficient interesting issue that I think there will be many things to discuss about. So the title of this talk is Quantitative Endpoints for Lung Recruitment. And for the ones of us that have been dealing with recruitment maneuvers at the bedside, we were at the beginning very fascinated by the rapid changes induced by recruitment maneuvers on patients, and we did not think about the effects on the long term. So we were not very concerned about the PEEP that we had to apply afterwards to maintain this recruitment. Then we shifted all our interest to the PEEP issue as we realized that this is also a very important issue, forgetting then the recruitment issue. And I think there are many, many important aspects of recruitment that we have to consider again in order to improve our understanding of the mechanisms involved in this relatively complex process. So by now you have seen already a few of these pressure volume curves, and the endpoint of lung recruitment is clearly shown in this graph. Here we have a theoretical, how can we, okay, yeah, the theoretical pressure volume curve, which is actually showing us all the possible universe of pressure volume relationships that we can ventilate along. And we know that ventilation in the area of low volume, low pressure, renders our lung to atelectasis and to the continuous process of opening and closing of airway and alveoli, one of the major mechanisms of ventilation-induced lung injury. Whereas if we ventilate the patients up here in high volumes, high pressures, we're submitting the lung to the risks of overdistension and gross power trauma. So recruitment, actually, what we're trying to do with recruitment is to set our tidal ventilation in this proportion of the pressure-volume relationship. The problem with this approach is that to get over here, we need to first go all the way up, that is, perform a recruitment maneuver and apply high pressures for a short time, and then look for the level of PEEP that maintains the recruitment and the tidal ventilation at this portion of the pressure-volume relationship. So both things are difficult because how do we know what pressure do we need to apply? And second, how can we quantify or how can we see at the bedside which is the PEEP level that we can apply to maintain the lung at this level? Well, definition of recruitment therefore means a change, a rapid and dramatic change in the lung condition. And we have to be prepared for that because all of a sudden we are in front of a different scenario when treating the patient. It's different because if you look at what happens in lung aeration, you see that for the same level of pressure, on the inflation portion of the pressure-volume relationship, we have this picture with a lot of atelectasis, a lot of pulmonary densities, whereas on the other side, once the lung has been recruited on the deflation limb with the same settings and the same pressure level, we have a much better aerated lung. And this is not only a nice picture, this also means a better pulmonary function. If we we studied systematically the response in 25 ARDS patients to different settings on the inflation portion of the pressure-volume relationship with the deflation portion of the relationship. So in this preliminary data of this study, we found that for the maximum compliance, that would be a target for ventilation on the inflation limb, looking at the maximum compliance, and this has been an approach proposed by Sutter many, many years ago. If you look at this point in maximum compliance and compare with the point of maximum compliance on the deflation limb, we can see that there's a 20% difference in lung compliance, which means that we can reduce the plateau pressures, we can reduce the tidal excursions of the lung. We are in a much better mechanical condition. So we have a much better functional situation. But if you look at the oxygenation, that is lung function, at these very same levels of PEEP, the one producing maximum compliance on inflation as compared with deflation, also we have a 57% increase in oxygenation, that is in lung function. So when we succeed to perform a recruitment maneuver, we have to deal with this changing scenario of the lung. Although sound, physiologically sound, recruitment is still a very controversial intervention. It's highly empirical. The lung at the bedside is still like a black box. We cannot see inside what's happening, and we only have a few. It's moving all the time. Yes. Thank you. So we only have a few elements of information, pieces of information that can help us to set our ventilator parameters in order to ventilate the patient in a protective way. So it's tremendously empirical and very dynamic, as you saw. Still, there's not a consensus which is the best recruitment maneuver. Many of you will probably question, is it needed at all? Do we need to recruit the lung, or is it better to rest the lung after all the impressive mortality results of the ARDS NET trial? Then another controversial issue is, how much should the lung be recruited? Do we try to aim for a complete lung recruitment to gain all the benefit, or is just a little bit of recruitment enough? To make things worse, there are no clinical outcome or safety data to date, and this is something that is needed, but it's difficult to plan a study when we still are in the phase of understanding what's happening. And the title of my talk, there's a lack of quantitative endpoints. So how can we define from a clinical perspective that we have a recruited lung and a stabilized lung for the long-term ventilation? If we look at the clinical studies performed in recruitment, the issue is not clarified very much. You can see there are a lot of studies shown in this slide, but in only 2 of them, of all these, there were a previous defined endpoint for recruitment. So they only applied several interventions, several modes of ventilation, combining pressures for a certain period of time. But these effects in most of these studies probably were not sustained because none of these studies actually dealt with the setting of an appropriate PEEP to maintain the effects of recruitment. So it's very difficult from these published studies to draw conclusions about the efficacy of recruitment at the bedside. We know that we have a transient improvement in lung function, in lung aeration, but in most of these studies, as I said, these effects are not sustained, and we do not know what happens on the long term, or if this has any impact, probably not in this way at all, on patients' outcome. So how can we define quantitative endpoints for lung recruitment? With this, we also have several problems. First, we need to select and apply a meaningful recruitment strategy at the bedside, the one that actually is taking us where we want to go with the lung. Then we need to find reliable and measurable endpoints. Reliable because they have to reflect the physiological condition of the lung, and ideally they should be available at the bedside for the clinician to use it all times. And another important issue that is very relevant to assess the quantitative endpoints is the timing when we do the assessment. So selection of application of a meaningful recruitment protocol. There are several recruitment maneuvers described in the literature. Some of them have been mentioned already. Oops, sorry. And the first one, and probably the most popular one, is the 40-40 type of recruitment maneuver, in which patients after a tidal ventilation are submitted to a CPAP maneuver in apnea, applying a pressure, inspiratory pressure, that is the recruitment pressure of 40 centimeters of water for 40 seconds, and then resuming ventilation. This type of maneuver is progressively abandoned because there are some studies showing that this is the type of maneuver causing the most problems on the hemodynamic side. In addition, 40 centimeters of water of pressure might not be enough for many of the ARDS patients. The next recruitment maneuver is it's a cycling recruitment maneuver in pressure control ventilation, and we call it single pulse because we perform a relatively rapid increase in pressure. This is what the recruitment maneuver we would use in relatively less sick patients, like patients with atelectasis after any surgical intervention, or in the very, very early phases of acute lung injury when the patient is intubated. So we have here a first increase in pressure to adapt the patient to the increase in thoracic pressure, and then we apply the recruitment pressures for a number of cycles, usually lasting 1 to 2 minutes, and then we reduce the pressure again, finding the level of PEEP afterwards. And the maneuver that has already been described by Bob Kaczmarek, the one that was proposed by the group of Marcelo Amato, is a sequential recruitment maneuver in which pressures are increased in a, as I said, in a sequential fashion, maintaining a safety level of PEEP and exploring different pressures. This recruitment maneuver is the one we have been implementing for the last years to explore recruitment in most sick patients, like ARDS patients. Here, we can actually titrate the recruitment pressure, and this is very important because if we can recruit a patient with 45 or 50 centimeters of water pressure, we do not need to go up to the very high levels of pressure. And important also is that after every increase in pressure, to assess the effects on lung function, that is, to quantify the effects of the recruitment maneuver, we have to reduce the pressure to the safety level and then make the assessment here. If we do the assessment during the moment of maximum pressure, we'll probably be blunted because of the high intrathoracic pressures and probably hemodynamic effects. So assessment in this type of maneuvers is always in the resting position, with a safety level of PEEP, which in ARDS patients is around 20 to 25 centimeters of water of pressure. And the problem is that the ARDS lung is very heterogeneously diseased. So we have different aerations in the lung. We have zones of poorly aerated tissues. We have zones of gross collapse. And we know that the opening pressures are distributed in a vertical gravitational gradient. In the study mentioned that has been recently published by the group of Marcelo Amato, they established that how was the frequency distribution of opening pressures of the lung as a function of airway pressure. And they saw that in the population of ARDS patients, there's 26 patients that they studied, the average frequency distribution of opening pressures had a bimodal shape, meaning that probably this first peak in opening pressures corresponds to the less sicker zones of the lung, the ones that are submitted to the superimposed pressure. But in the most dependent parts of the lung, the most sicker parts of the lung, we have degassed alveoli with debris, with sticky atelectasis that are very difficult to open. So to recover those areas, we probably have to apply pressures that are much higher than the usual pressures referred in the literature. So these are the areas of the lung that we would like to recover, and this is why in these very sick patients we need to apply, as a rule, higher pressures. And they show an example, because in addition to the opening pressures, these very sick lungs, the areas of the lung also have higher closing pressures. So here's a patient with an ARDS, and this is the CT scan image at a PEEP level of 0. The quantification of collapse shows almost 40%. And then this patient is submitted to a maneuver consisting of 40 centimeters of water and a PEEP level of 17 centimeters of water. Here we have a reduction to 10% of lung collapse, but still we can see some atelectatic areas in the most dependent parts of the lung. So this can be due to two problems. One, maybe the recruitment pressure was not high enough, 40 centimeters of water. But also, it could be that 40 centimeters of water would have been enough, but 17 centimeters of water of PEEP would not be able to stabilize the lung. And there's no way that we can find out with only this picture. And this is something we have to take into account when we interpret the results of recruitment maneuvers in the literature and in our patients. It depends on when we do the assessment. Have we done the CT scan at an inspiration? Have we done it at an expiration? All these factors influence our interpretation of the results. So this patient was further submitted to a new recruitment maneuver with 50 centimeters of water pressure this time, but also an increase in the level of PEEP to maintain the recruitment. And here the collapse was reduced to 0.8%. So here probably the combination of the two factors played a role, the high inspiratory pressures and the high level of PEEP maintained after the recruitment. What about reliable and measurable endpoints? Well, for the assessment of lung recruitment, we can assess it from a morphological point of view with CT scans. This is obviously not a clinical tool, but the CT analysis of the area's lungs and patients under mechanical ventilation has taught us very much about the response of the lung to different maneuvers and different interventions. But the clinician has to rely on functional changes, especially in gas exchange, and still the most used parameter is oxygenation, but also in lung mechanics, which is becoming more and more important, especially the changes in compliance or elastance. Also, PV curves have been studied, although at the bedside are not that easy to perform and not so easy to interpret. And also the changes that we can induce in an expiratory lung volume, but also these changes are very difficult to interpret. To what extent are they occurring? And I will give some words about the expired CO2 analysis, the single breath test of CO2, because there could be also signals that we could interpret in terms of the changes in the efficiency of ventilation induced by recruitment. So there are many studies showing the close relationship and correlation between the atelectasis in the lung and the level of shunt. And to pay credit to a group that has done the pioneering works in CT scan analysis and putting into relation the development of atelectasis and shunt is the group of Göran Höncherna from Sweden that had several studies showing that this correlation between shunt and atelectasis. So we performed an experimental study, and the study was meant to look for the optimum PEEP, but also to be sure that we were starting from a completely fully recruited lung. We predefine a priori the recruited lung in terms of oxygenation with a PO2 more than 400, with a shunt that corresponds to a shunt less than 10%, and a dynamic compliance of more than 30%, that is the increasing compliance after recruitment. This is also measured by a FiO2 of 1. Why FiO2 of 1? Why such a high PO2? Well, we need to magnify the signal of lung recruitment and to simplify the mechanisms of gas exchange. When we use FiO2 of 1 in conjunction with recruitment maneuvers, the mechanism of gas exchange is related to the relative proportion of only two compartments, the one that is totally collapsed and the one that is opened. Why? Because the poorly aerated regions that are creating VQ mismatch will probably tend to disappear or have less importance. First, because If they're poorly ventilated with 100% oxygen, they will disappear. They will go to the collapse compartment. Or either if they can be maintained patent, the only gas affecting those regions will be oxygen, because all the nitrogen will have been washed out. So it's a simplification of gas exchange, and allows us to a better interpretation of the gas exchange phenomena that occur in the lung with the recruitment maneuvers. And of course, we correlated this with the amount of non-aerated tissue on the CT scan, getting a threshold of less than 5% in the area of non-aerated tissue compared to the total section of the lung. Well, we studied 8 animals. The model was a lung lavage porcine model. We know that this is a very homogeneous model, easy to recruit, but that was exactly what we wanted to study, the effects of recruitment and lung collapse. So with this recruitment maneuver with fairly high pressures for the type of model we were using, we obviously were able to achieve a completely fully recruited lung in terms of oxygenation, reduction in shunt, and an increase almost more than double in dynamic compliance. We found like other authors, a correlation between PO2 and the percentage of non-aerated tissue with a high correlation, and a negative correlation between PO2 and non-aerated tissue. Well, what happens in ARDS patients? In the study of the group of Marcelo Amato, they found a partial correlation in a statistical multivariate model in which they showed that the PO2 correlated very well with the mass of collapsed tissue measured on the CT scan. Furthermore, they saw that whenever, and these are individual patients with each of the different figures, whenever the percentage of mass of collapsed tissue was in the range of 5 or less %, all patients, or the majority of patients, had a gas exchange reflecting a PFO2 ratio above 350. Another index that they tried to validate in this study, and they actually did, was the sum of the PO2 plus the PaCO2 as an index of maximal recruitment. Why this? First, because the type of recruitment maneuver, the sequential recruitment maneuver, is using a very high pressure during a very long time with high levels of PEEP to maintain recruitment, and over this high level of PEEP of 25 inspiratory pressures that can reach eventually 60 centimeters of water. This, of course, creates a situation of hyperventilation and an increased amount of CO2. And in the situations where we reduce the shunt very much, below 10%, there is a almost linear relationship of 1-to-1 of the reduction in PO2 when the alveoli get invaded by CO2. So to have a better estimation of the aeration of the lung, Amato proposed the sum of the PO2 plus the PaCO2. And they found in this analysis of a residual operating curve that the sum of these two parameters, about 400, had a high sensitivity and specificity to detect more than 5% of lung collapse. Taking this index for defining full recruitment, they saw that from the 26 patients, almost 50% could be recruited with pressures of 40 centimeters of water, and only a smaller proportion needed higher pressures. This is actually a surprising result, because we know, again, from the group of Hennicerna, that even healthy patients with atelectasis induced after induction of anesthesia require 40 centimeters of water to get rid of the atelectasis induced only by the induction of anesthesia, measured by the CT scan. So if healthy patients need this pressure, it is unlikely that patients with ARDS can be recruitable with 40 centimeters of water. maybe the issue here is the PEEP that is used. Again, the problem of how to interpret the results of recruitment with high inspiratory pressures and the level of PEEP that is applied with them. In the patients that we studied, we found that taking a criterion of a PO2 of about 350 milliliters of mercury, 25 patients with ARDS submitted to a recruitment maneuver with a plateau pressure of 60 centimeters of water of pressure. Almost all of them fulfill this criterion, excepting 4 patients. If we take the 400 millimeters of mercury limit, we found that many patients, or many more patients, did not reach this criterion, but all of them had some degree of hypercapnia, and when we summed the amount of CO2, only 1 patient was not fully recruited according to this definition in this study. What about changes in mechanics, in lung compliance? We should expect that with a sequential recruitment maneuver in which inspiratory pressures are progressively decreased, we will gain more lung tissue, and this will have an effect on lung distensibility, as this particular example is showing, that with each incremental PEEP step, we have an increment in lung compliance. In the study of Amato, and I'm showing a lot of data of this study because I think it's giving very important information for us to understand the mechanisms of recruitment, and also because in the initial phase of this study, I had the chance to participate in at least managing a few of these patients. So there's also a small emotional component with this. So they found that also the patients submitted in his study to increasing levels of pressure had a continuous increase in compliance, reaching about 15% compared to the baseline setting of 40. And remember that the evaluation is done at the moment where the inspiratory pressure is reduced and the level of safety level of PEEP is maintained of 25 centimeters of water. Also importantly is that within regression of the analysis of the patients, they saw that there was a good correlation between the arterial PO2 and the increasing compliance, showing an increasing slope, excepting those patients here in the red circles that did not have any recruitment effect. What about volumetric capnography? Well, when we look at the Excel CO2, we're actually having a picture of how the gas is abandoning the lung, and this gives us a good information about the efficiency of ventilation. We know that there are several phases, but we're interested in looking at the changes in the slope of phase 2 and phase 3. Phase 2 is the gas transport due to convection. That is the first gas coming from the alveoli out to the main airways. And the slope of phase 3, which is the gas coming from the alveolar compartment, which is also dependent on the lung perfusion. Well, we have repeatedly seen, especially in more healthy patients, that when we have a partially collapsed lung, we have an increase in the slope of phase 3 and a decrease in the slope of phase 2. We know also that the area below the single breath test of CO2 refers to the amount of CO2 eliminated per breath. That is also an index of efficiency of ventilation. When these patients are recruited, we increase the efficiency of ventilation, and this is reflected by an increase in the slope of phase 2 and a decrease in the slope of phase 3. And we thought that this might be a good signal, non-invasive signal at the bedside, to see if we have induced a morphological change in the lung with the recruitment maneuver. We studied initially in this publication 16 patients after cardiac surgery or during cardiac anesthesia. We confirmed a recruitment effect by the increase in compliance, an increase in oxygenation, and an increase in expiratory lung volume. And we saw a significant decrease in the slope of phase 3 and a significant increase in the slope of phase 3. Meaning that maybe in these non-invasive analysis of the single breath test of CO2, we have some additional information of the changes, the 3D morphological changes of the lung induced by recruitment. So is this also applicable in patients with ARDS? We are currently evaluating this as any other type of functional study. ARDS patients are very complex, but it is only an example of a very sick ARDS patient in which we can see the changes in the morphology of the single breath test of CO2 from a fully completed, fully recruited situation to a progressive collapse condition. You see that the slopes of phase 3 are increasing, the slopes of phase 2 are decreasing, and especially the area below the curve, that is the efficiency of ventilation, the efficiency of CO2 elimination, is progressively decreasing. So, and finally, the timing of assessment is also important. We know that if we don't apply the right level of PEEP, all the beneficial effect of recruitment are lost immediately, here in a few minutes, 20 minutes, after having gained a better oxygenation, a better lung mechanics, and an increase in the recruited volume. So if we make our assessment after reducing the recruitment pressures without PEEP, we probably won't see any effect of the maneuver. In Marcel's Amato study, they also tried to maintain the stable open lung condition for a number of hours, and the patients studied in the ICU for 6 hours, and they were, in terms of oxygenation, maintained stable with the optimum PEEP set at 20 centimeters of water. This is also another study showing the same effect with a recruitment maneuver with a previous definition and a right setting of PEEP. They could maintain the open lung condition for several hours, even for several days, without any change. So in summary, what are the quantitative endpoints that we can use at the bedside? We can use oxygenation, and the indexes that will probably reflect a open lung condition are the PFO2 ratio above 350 or the PO2 more above 350. The sum, like I just showed, the sum of PO2 plus PCO2 above 400, or a shunt fraction, which is the correspondent to this functional situation, less than 10%. And lung mechanics, probably if we get an increase in 15 to 20% in lung compliance, we can be quite confident that we have induced a major recruitment effect in the lung. So in conclusion, the dynamic changes in oxygenation and lung mechanics are useful clinical quantitative endpoints for estimating recruitment. A majority of early ARDS patients respond to individualized maximum recruitment maneuvers. And of course, new additional monitoring options will improve our understanding of the complex recruitment collapse phenomenon. Thank you.
Fernando, thank you very much for a comprehensive review of recruitment maneuvers. Any questions from the audience? Question at the back? While the mic is getting there, can you send the mic to the back, please? Let me ask you, one of the issues I don't think you dealt with, Fernando, is it beneficial to recruit the lung fully? You know, from a clinical perspective, is that you pay a price, you might need PEEP of 25, you might need PEEPs higher than 25. So in terms of clinical outcomes, could you talk about the clinical outcomes associated with this improvement in recruitment?
Well, I can't talk about outcomes because this has not been assessed already. I would say that, you know, how can we establish full lung recruitment? This is the first problem. Unless we have some morphological information or a really reliable functional information that we have a completely recruited lung, because these are all approximations, and these are studies that are physiologically based, and we have a period of time in which we do the assessment. We don't know if this will be going on for the next hours, for the next days, and we also know that every time we perform recruitment maneuver, the situation might change. So from a pathophysiological point of view, I would say, yes, I would try to obtain the maximum recruitment as possible. Why? Because I don't like the idea or better said, I don't believe in the idea of the resting lung. I think atelectasis are causing damage not only in the atelectatic regions, but in the rest of the lung. It's deteriorating the distribution of the homogeneous distribution of ventilation, so making the lung more prone to overdistension. And no matter how much we reduce our tidal volumes, we will never get rid of some effect of tidal recruitment. Because whenever we have lung collapse, we will have tidal recruitment. The only way that we know that we, or at least try to minimize as much as possible, is if we can get rid of the much amount of collapse as possible.
But I don't think you've addressed, the potential over. We had a discussion with Bob Kazmarek about and John Marini about is 25, 30. You're talking about peeps of 25 or maybe higher. So clearly keeping the peak pressure less than 25 or plateau would be a little difficult. So that's the trade-off I'm talking about. I mean, I think that if you didn't have a price to pay with overdistension, I think we'd all agree. So that's really, and I know there's no answer, but I think it's worth a debate because, you said the first question is, how do you decide if the lung is fully recruited? Another question is, should we fully recruit the lung? But anyway, there's a question at the back.
Yes, we're being cautioned by these studies not to ventilate to target normal blood gas values. However, some of these studies are correlating morphological changes of the lung with these same parameters. How does the clinician at the bedside reconcile that?
No. Could you make the question again, because I didn't hear it?
No, we're saying we're being cautioned not to ventilate to target specific, like normal blood gas values. However, some of these studies are correlating morphological changes of the lungs with these same blood gas parameters. For example, PCO2, PO2, oxygenation and ventilation. How does a clinician reconcile this at the bedside?
Well, I'm not promoting that we need to ventilate our patients with optimized gas exchange. I was trying to make the point that we need some information to assess what's happening inside the lung. And the information that we have available at the bedside is gas exchange, is lung mechanics. So we use this to monitor the response to recruitment. So we are using all these criteria only for the period in which we are challenging and studying the lung. Once we know the pressures in which we achieve a full lung recruitment, once we know the pressures, the PEEP level that maintains this recruitment, we can return to the normal approach of lung protection and maintaining a condition not focused on gas exchange. I don't know if this is... So
you're advocating trending rather than... So you're saying we should trend these values rather than targeting like normal, quote, normal values? Like trend the values for a particular patient rather than to look for the textbook normals, so to speak?
No. I would say that this, if I can just add to Fernando's point, I think he's saying that this is the test. So when you do the test, you want to get high PO2s because that tells you there's recruitment. That doesn't necessarily mean that then when you then ventilate the patient for hours that you necessarily have to have these high values. That's how I would interpret it. I think though the other caveat, of course, is that before we adopt this, I'd like to see more evidence in terms of some clinical outcome, because yes, you can open the lung, and I think that there's pretty good data to suggest that that's going to be beneficial, but there is a downside. I think we have to address that. Question at the back, then up at the front.
And there are other downsides. And many of the patients we see with ARDS are hemodynamically unstable, septic shock, and so on, may not tolerate the hemodynamic effects of the recruitment maneuver or the high levels of PEEP that you're suggesting. In addition, many of our patients have underlying COPD or necrotizing pneumonia, and if they develop the old-fashioned barotrauma with a tension with a pneumothorax and a bronchopleural fistula, in that setting, it's probably a fatal complication. So are there patients you don't do this maneuver in, and how do you deal with these complications?
Yeah, one of the most important aspects of a lung protective ventilation strategy, especially if you use recruitment, is that you have to individualize it to the particular patient. So we would never challenge the lung in this way if the patient is unstable. We would first try to stabilize him and then perform the procedures. And of course, this is not a treatment free of complications, as you just pointed out. And there are some particular situations in which we have to be extremely careful, like necrotizing pneumonias, for example, because the risk of trauma is very high. Even though I think if you have a rational protocol and rational approach in which you do a hemodynamic stabilization and you do a sequential approach to recruitment, I think most of the patients will finally be able to be recruited, and in these patients we will end up being able to implement a lung protective ventilation strategy based on recruitment.
Final question out the front, then we'll go for lunch. So leave that for Fernando speaking afterwards. So we'll give him a chance afterwards. Right at the front, Rolf.
It strikes me that neither you nor Bob have talked about the Gatineau paper in the New England Journal of Medicine, which had sort of made the point that actually not that much of the lung is recruitable in at least the patients that he selected to study. And I wonder whether you want to make a comment about this.
Yeah, I was tempted to comment this study. The thing is that I think in Gatineau's study, he is not exploring the full potential of recruitment, and I think this is the main limitation. So if you select one single option to treat the patient in terms of pressure, then what you can end up concluding is that you have a population of patients that will respond to that specific maneuver. And again, mechanical ventilation, especially when we're challenging the lung, must be an individualized treatment. And even in Marcelo's Amato study, many patients were already recruited at 40 centimeters of water. So we don't need to explore the higher pressures. But the ones that were recruited with high pressures, we cannot declare them as non-responders. They're not responders to 40 centimeters of water. I think this is the main issue with the Gatineau paper, that you choose one setting, one pressure, and look what happens in patients, and then you infer and you draw conclusions about the recruitability of the general population. And I think this is at least blunting a little bit the whole picture on the whole potential of recruitment.
Bob wants to just give a comment. Okay, let's have another couple comments. You can't have dessert. That's the trade-off here. Because we're going to have to get back at 1:15.
Yeah, just to answer your question, the way I think there are a number of big differences between the Amato trial and the Gatineau trial that led to very different outcomes. And the first one is the timing. If you look at the timing of the patients studied by Gatineau, it's 5 days plus or minus 7. Again, these are patients way out in the length of time they're ventilated that over and over again have been shown to be non-recruitable. He studied the wrong patients, in my opinion. Amato studied patients 1 to 2 days for the most part. The average length of time was 2-point-some days that they were mechanically ventilated. Secondly, if you look at his protocol, not only did he not go to high pressures, but after every attempt, he came to 5 a peep. So he de-recruited the lung that he just recruited, so that his assessment, although it was at a later time up to, I'm trying to remember, I think it was 20 centimeters of water where he did the assessment, he allowed de-recruitment after each of his recruitment maneuvers, so that he created a protocol that was doomed to failure as far as the level of recruitment that he was able to determine. I mean, I think it was a poorly designed study from the perspective of ensuring maximum recruitable lung.
Yeah, there are many aspects, but also the time, as you said, of course it is important, but that doesn't mean that patients with 6 or 7 days of evolution are not potentially recruitable. But probably these patients will need extremely high pressures if you want to have a recruitment effect. So it is a recruitment maneuver, and lung protection is exactly that, protecting the lung, preventing, so applying it as soon as possible in the evolution, but not a certain number of days precludes the response to recruitment.
There's a final, this gentleman's been waiting.
It's striking on your CT slides how much of the de-recruited lung is deep.
Can you hear over there?
Can you hear it okay?
Here you go, guy.
How much of the recruited lung is dependent on the CAT scan? This is something we see again and again clinically, and it just makes me wonder whether, have you looked at proning as a recruitment maneuver? Do you have any?
Yes, well, proning, in fact, is a recruitment maneuver. By the changes you induce in the transpulmonary pressures, you are actually having some effect, probably only recovering a limited number of lung areas, but proning per se is changing the equilibrium, the pressure equilibrium inside the lung, and creating some recruitment effect. I think proning can be have a good synergistic effect to recruitment, and probably patients proned are easier to recruit and especially easier to stabilize with PEEP because of the disappearance of the vertical pressure gradient. So yes, we have tried it, and I would call proning a recruitment maneuver, an incomplete but a recruitment maneuver.
Thank you very much, Fernando.